Imagine looking at an X-ray of your spine and knowing that in just a 5 to 10-year window, 1/5 of the solid white bone you are looking at is just going to completely vanish.
It's a terrifying visual, honestly.
Right. I mean, that is exactly what happens to a woman's skeleton during the menopausal transition.
Yeah, we tend to look at skeletons as these permanent, static structures.
Exactly. But today we're stripping away that illusion completely. Welcome to the deep dive. Our mission today is to uncover the exact microscopic link between menopause and the sudden, drastic increased risk of developing osteoporosis.
And we have a really fantastic stack of sources for this.
We do. We are pulling from advanced clinical practice guidelines from the British Menopause Society and IC, alongside some really comprehensive biological reviews on the molecular mechanisms of bone loss.
So we're really getting into the cellular warfare happening in there.
Yeah, the invisible stuff. So whether you are approaching this transition yourself or, supporting a loved one, or you're just fascinated by human biology, this deep dive is going to take you straight into that microscopic battle happening inside the skeleton during midlife.
Because you really have to understand the baseline before you can understand the disruption.
Right. Okay, let's unpack this. Before we look at how menopause breaks the system, we have to establish how a healthy skeleton actually functions.
Yeah.
Right.
Exactly. Because that assumption of permanence we talked about, it's completely shattered the moment you look at bone tissue under a microscope.
It's basically a highly active tissue.
Oh, it's a highly volatile environment. I mean, a healthy adult body turns over and replaces roughly 20% of its bone tissue every single year.
Wow, 20%.
Yeah. You are essentially regenerating a new skeleton continuously through this bone remodeling cycle.
Which takes a while, right?
Right. It operates locally in these distinct sites across the body. And each individual cycle takes anywhere from 4 to 8 months to run, from activation all the way to quiescence.
Right. And you've got two main cellular players executing this constant turnover. Reading through the biological reviews, it operates a lot like a city's road network.
Yeah.
Under constant, simultaneous renovation.
That's a really good way to look at it.
Yeah, so you have the demolition crews, the osteoclasts, tearing up the old asphalt, and then the paving crews, the osteoblasts, laying down fresh roads.
Right. And what's fascinating here is the origin of those cells. They come from entirely different lineages.
Oh, really?
Yeah, which dictates how they function. So osteoclasts, the demolition crew, they are these massive multinucleated cells derived from myeloid stem cells.
So they share a lineage with the immune system.
Exactly, with macrophages. So they attach to the bone surface, form this super tight seal, and then use proton pumps to secrete acid and proteolytic enzymes.
Just literally dissolving the hard mineral matrix.
Yeah, and the enzymes break down the collagen proteins. They are excavating a microscopic pit.
And then the paving crew comes in.
Right. Following closely behind are the osteoblasts, and these are derived from mesenchymal stem cells.
Okay, so totally different origin.
Completely. These are mononuclear cells that move into that excavated pit and secrete osteoid.
Which is the unmineralized matrix, right?
Exactly, a soft matrix of collagen. And over time, this osteoid mineralizes by pulling calcium and phosphorus from the bloodstream to form new, structurally sound bone.
But wait, if these two distinct crews are operating continuously across, thousands of microscopic sites, what stops the demolition crew from just destroying the whole city? I mean, the potential for structural failure seems incredibly high.
Well, it is, and that's why the survival of the entire skeletal system hinges on a concept called coupling.
Coupling?
Yeah. Bone renewal only maintains skeletal strength when the resorption of old bone is perfectly matched with the formation of new bone.
Okay, temporally and spatially.
Right. It requires a master site manager to regulate the crews to ensure the osteoclasts don't just outpace the osteoblasts.
And this is where the hormones come in. Specifically, estrogen is the primary regulator maintaining that coupling in women.
Exactly. It's the ultimate site manager.
Because looking at the biochemistry, estrogen isn't just, sending a broad signal. It's acting as a very specific molecular brake on those demolition crews through the TNF superfamily of proteins.
Right, and the literature really focuses on 3 specific proteins here.
Yeah, RANK, RANKO, and OPG. So how do these 3 actually interact on the ground to manage this coupling?
Well, RANK is a receptor. It's located on the surface of the osteoclasts and their precursor cells.
Okay.
And RANK ligand is the primary binding protein that activates that receptor.
So when RANKL binds to RANK,
it triggers a signaling cascade. And that drives the formation, the activation, and the survival of the osteoclasts. It is literally the direct biochemical command to destroy bone tissue.
So Arakel is the work order for demolition. But the osteoblasts, the bone-building cells, they are the ones actually secreting this Arakel, which seems, well, it seems completely counterintuitive. They're actively signaling for their own construction site to be torn up.
They are, but they also secrete OPG, osteoprotogerin.
Ah, okay, here's where it gets really interesting.
Yeah, OPG is a soluble decoy receptor. It just kind of circulates in the local microenvironment, and it has a really high affinity for Arakel.
So it basically grabs the Arakel before it can reach the actual demolition crew.
Exactly. By binding to rangakel before it can ever reach the rank receptors on the osteoclasts, OPG neutralizes that destruction signal.
So if I'm getting this right, the osteoblasts are essentially throwing out fake decoy targets at the demolition crew to distract them so they stop breaking down the bone.
That is exactly what they're doing. And this is where estrogen's role becomes the linchpin. Estrogen actively suppresses the expression of Arankel while simultaneously upregulating the production of OPG.
It's effectively acting as a brake, cutting off the demolition signals and flooding the zone with decoys.
Flooding it. And on top of that, estrogen increases the production of TGF-beta.
Which causes osteoclast apoptosis, right? Cell death.
Yeah, it actively limits their lifespan. Estrogen is the definitive brake on bone breakdown, but the mechanism also extends deep into the immune system.
Wait, how does the immune system factor into bone remodeling?
Well, the bone marrow is a major lymphoid organ, and when estrogen levels are sufficient, it keeps the local immune cells in check. The T cells and B cells in the marrow are highly sensitive to estrogen.
So, what happens during the menopausal transition when that estrogen brake is suddenly removed, when the ovaries just stop producing it?
The microenvironment undergoes a massive inflammatory shift. Without estrogen, the supply of decoys plummets. And those T cells and B cells, they begin producing high levels of inflammatory cytokines.
Like interleukin-1 and TNF.
Exactly, IL-1, IL-6, and tumor necrosis factor. These cytokines are potent stimulators. They drastically amplify our NKL expression.
Wow. So the decoy supply drops, the destruction signals multiply exponentially because of the inflammation, and that perfect coupling is just entirely lost.
Completely. The demolition crew goes into an unrestrained frenzy. Resorption outpaces formation incredibly fast.
And the timeline for this uncoupling is much sharper than people generally think, right? Like, the most rapid period of bone loss doesn't happen a decade after menopause.
No, not at all. It begins in a very specific transmenopausal window, starting roughly 1 to 2 years before the final menstrual period.
Before it even ends.
Yeah, and lasting until about 2 years after. The clinical data on this specific window is just staggering.
Let's talk numbers because they are dramatic.
Well, annual bone mineral density loss can hit 2.46% at the lumbar spine and 1.76% at the femoral neck.
Just in 1 year.
Right, and when you compound those rates over a 5 to 10-year transition, women can lose up to 20% of their total bone density. The structural degradation is profound.
And it translates directly to major clinical outcomes. I mean, the sources say 1 in 2 postmenopausal women will suffer a major fracture.
1 in 2. Fragility fractures occurring from standing height or even less.
And hip fractures are especially terrifying. They carry a devastating 20 to 30% mortality rate within the first year.
Yeah, largely due to complications like immobility, pulmonary embolisms, pneumonia. It's a systemic trauma.
Which is such a sharp contrast to men.
Very much so. Men definitely experience bone loss as testosterone gradually declines, but they generally achieve a higher peak bone mass, their long bones are wider, and that hormonal decline is linear. It's gradual over decades.
They don't fall off that sudden cliff of hormone withdrawal.
Right, they bypass that abrupt uncoupling.
So what does this all mean for specific areas of the body? Because you mentioned the lumbar spine loses 2.46% annually right away. Why is the spine specifically so vulnerable compared to like other bones?
Well, it comes down to surface area and metabolic turnover rates. Our skeleton has cortical bone, the dense outer shell, and trabecular bone, which is that spongy, honeycomb-like internal network.
Okay.
The vertebral bodies in the lumbar spine are predominantly trabecular bone.
Oh, and because trabecular bone is made of all those microscopic interconnected plates, the surface area is massive.
Exactly. It provides exponentially more physical space for osteoclasts to attach and start remodeling. It deteriorates much faster than cortical bone when estrogen drops.
Because there's just more surface for the demolition crew to work on simultaneously.
Right. If we connect this to the bigger picture, When the sheer volume of osteoclast activity causes rapid thinning and perforation of that microarchitecture, the connections are severed. And once they're severed, the osteoblasts have no physical template to lay new bone down on.
The structural loss is permanent.
Yes, this is why vertebral fractures often happen first, sometimes silently. A patient might just notice a loss of height without realizing they're experiencing cascading microfractures. It's why early intervention in this specific window is so crucial.
That makes total sense. But this sudden drop in estrogen doesn't happen in a vacuum, right? The biological reviews highlight several other threat multipliers during this exact same midlife period.
Yeah, there are several compounding factors. Sarcopenia is a massive one.
The progressive loss of muscle mass.
Right. The clinical guidelines stress that women with low muscle mass present with fracture risks 2 to 3 times higher than their peers.
Independent of their actual bone density.
Entirely independent. Because diminished muscle mass alters gait, impairs balance, and removes the mechanical dampening effect during a fall. If you can't catch yourself, the impact force goes directly to a compromised bone.
Wow. And speaking of body composition, I want to push back on something. I saw this detail in the British Menopause Society sources regarding body weight that seems to contradict typical health advice.
The BMI data?
Yeah. The sources state that non-obese women actually lose bone at a faster rate than heavier women during menopause.
Wait, so having a higher body mass index might actually provide a protective buffer against bone loss?
It's a counterintuitive fact, yeah. Heavier mechanical loading does stimulate osteoblast activity, resulting in higher bone mineral density on a standard scan. But we have to emphasize the vital distinction between bone quantity and bone quality.
Okay, explain that.
So obesity is often associated with metabolic syndrome and type 2 diabetes, right? Which creates a highly toxic microenvironment for the bone matrix. The chronic hyperglycemia and oxidative stress degrade the actual collagen matrix.
Ah, so the structure itself is compromised.
Precisely. So a patient with type 2 diabetes might show normal or even high bone mineral density, high quantity, but their fracture risk is still incredibly high due to poor microarchitecture. The bone is stiff and brittle.
Quality over quantity, that makes sense. We also have to factor in secondary causes like medications. The literature is pretty harsh on glucocorticoids. Steroids, yes. They actively hijack the mesenchymal stem cells in the marrow. Instead of becoming bone-building osteoblasts, the glucocorticoids force those progenitor cells to differentiate into fat cells.
So you're literally filling the bone marrow with fat while starving the skeleton of new osteoblasts.
Exactly. And we also have to mention genetics. 50 to 85% of osteoporosis risk is genetic.
Heavily linked to the maternal side, right?
Yeah. Specifically, polymorphisms in the estrogen receptor genes, ESR1 and ESR2, which dictate how aggressively your bone will react to the withdrawal of estrogen.
So given this, multi-front assault on the skeleton, the lack of decoys, inflammation, sarcopenia, genetics, how do we measure the damage? The guidelines focus heavily on assessment.
The gold standard is still the DXA scan. It gives you a T-score. -1 to -2.5 is osteopenia, and anything below -2.5 is osteoporosis.
But DXA has limitations, right? It only measures 2D density, not the bone quality issues we just talked about.
Which is exactly why the guidelines universally integrate the FRX algorithm now. It calculates a 10-year absolute fracture probability using your T-score plus clinical risk factors.
Age, BMI, family history.
Right. And once we assess the risk, we have to look at action. And the NICE and British Menopause Society guidelines are very clear. For menopausal women under 60, hormone replacement therapy, HRT, is the first-line intervention for preventing osteoporosis.
Because it effectively replaces the brakes. Is starting HRT essentially like hiring back the original site manager to restore order before the demolition crew ruins the city's foundation?
That's the perfect analogy. It introduces exogenous estrogen, suppresses the RNKL, boosts the OPG decoys, and halts the inflammation.
But we have to address the risks objectively.
And of course, combined HRT does have a slight duration-dependent breast cancer risk, but estrogen-only HRT for women who have had a hysterectomy has little to no risk.
And the route of administration matters too.
Massively. Oral estrogen has blood clot risks, but transdermal estradiol patches, gels, bypasses the liver entirely and lowers those clot risks.
And this raises the point about timing. The window of opportunity.
Right. This raises an important question about when to start. Initiating HRT within 10 years of menopause, generally before 60, is vastly superior to waiting until a fracture occurs. It lowers all-cause mortality and heart disease.
It's preventative, but it's not the only pillar. Lifestyle interventions are mandatory.
Yes. 1,000 milligrams of calcium daily, vitamin D, and progressive resistance training 2 to 3 times a week.
You have to actually load the skeleton.
Right, the metabolic availability of calcium means nothing if the osteoblasts aren't receiving mechanical signals from lifting weights to actually utilize it.
So to wrap this up, bone health isn't just a passive waiting game. Menopause flips a molecular switch that accelerates bone breakdown. But armed with the right knowledge about estrogen, DXA scans, and strength training, you have the power to protect your skeletal structural integrity.
And I want to leave everyone with one final concept to ponder. We briefly touched on how the bone matrix serves as a major source of growth factors.
Mm.
Well, we now understand that osteocytes, the cells inside the bone, act as sensory endocrine cells. They secrete hormones like osteocalcin that communicate directly with the pancreas, the brain, and muscle tissue.
Wait, so the skeleton is communicating with the rest of the body?
Exactly. What if we viewed protecting our skeleton during menopause not just as a way to prevent fractures, but as the secret key to preserving the hormonal and metabolic health of our entire body?
Turning our bones from a simple structural frame into a master regulator of biological aging.
Exactly. It changes everything.
That is profound. Keep questioning the consensus, keep examining the data, and we'll see you on the next deep dive.